Hello everyone and happy Monday. I apologize for my voice as I have a pretty bad cold. But my name is Kaylee Seedorf and I will be doing my TED Talk on polycythemia today. But before we get any further, I would like to dive right into a case study. This case study will kind of explore throughout the video. A 65-year-old man named Jack presents to the emergency department complaining of fatigue of several months' duration. He has extreme itching when around water, and he has the development of chest pain. He has a past medical history of metastatic testicular cancer that successfully treated in 2004. He currently has no evidence of disease. An EKG shows no evidence of myocardial infarction or concern for a pulmonary embolism, and his chest x-ray is unremarkable. He also had labs performed in the ED and revealed a white blood cell count of 18,000, a hematocrit level of 67%, hemoglobin of 23, and platelets of 600,000. Now you might be asking, what is polycythemia? This is a condition of increase of red blood cells in the body. There are two forms of polycythemia and two main subtypes of one of the forms of polycythemia that we'll explain a little bit further into this video. You may be thinking, whoa, Kaylee, I'm so confused. But don't worry, you guys. I want you guys to buckle up and hang on because we'll get through this together. So we know that red blood cells are produced in the bone marrow. The hematopoietic stem cells are stimulated by erythropoietin, and polycythemia in turn can be triggered by either increased production of the erythropoietin or excessive division of the hematopoietic stem cells, thereby increasing red blood cell production. This is most often caused by the genetic mutation of the JAK2 gene, which we'll talk about a little bit later. Now, according to Liu and Chang, polycythemia can affect all ethnic groups, primarily the age of 60, and more cases in men than women. Rogers 2023 also states that those of white of Eastern European Jewish descent are more at risk for developing this condition and is rarely seen in children. According to Grunwald, polycythemia in the United States, there's 44 to 57 cases per 100,000 people that develop this every year. Now let's talk about pathophysiology. There are two forms of polycythemia. The first is relative. This results in the human concentration of blood associated with dehydration that may be caused by decreased water intake, diarrhea, excessive vomiting, or increased use of diuretics. Increased fluid intake, orally or IV fluids, are often given to correct this condition. Now, if you're still with me, we'll move on to the next type of polycythemia. This is known as absolute polycythemia. This type has the two types: primary, which is known as polycythemia vera, and secondary polycythemia. We'll start with the secondary polycythemia, and then we'll go into polycythemia vera, as that has a larger range of problems. With secondary polycythemia, this result is due to another condition such as kidney disease, tissue hypoxia, certain tumors, and hormone-related medications. As stated previously, we know relative polycythemia develops through some condition that has to be corrected. The same goes with secondary polycythemia. According to Rogers 2023, this is the most common form of polycythemia, and it's often a physiological response to hypoxia, leading to increases in the erythropoietin secretion when we need to correct that, which we need then to correct. The second type, or the primary type of polycythemia, is polycythemia vera. This is a stem cell disorder with hyperplastic and neoplastic bone marrow alterations and is considered a slow-growing blood cancer. This is most often caused by the Janus kinase 2 gene, or best known as the JAK2 gene mutation. This causes the cells to have an abnormal, uncontrolled proliferation of red blood cells and platelets. Johns Hopkins Medicine states that roughly 95 to 98% of cases of polycythemia are due to the gene mutation of JAK2. With the JAK2 gene, we must explore the reason why. Normal JAK2 protein increases the activity of the erythropoietin receptor and self-regulatory so that JAK2 activity diminishes over time. This mutation causes an excess number of blood cells, which then in turn can cause thrombus or occlusion, which can cause tissue injury or death. Now, as a provider, we must ask our patients pertinent history questions such as symptoms and elevated labs in the past. Some expected findings. Our patient would often present with potential thrombi or thrombic occlusion, which can lead to decreased peripheral circulation and pain and hypoxia, which is not fun for anyone. They also may have a headache. They may be drowsy, delirium, mania, psychotic depression. They may just have no energy levels. They also would have blurred vision and episodic blurred vision. One of the telltale findings is this intense, painful itching that becomes worse with heat or water. This is known as aquagenic pruritus, and this is due to the increased number of mast cells. The patient may also have petechiae, enlarged spleen, or Raynaud syndrome. One thing to note with the painful itching is that Benadryl is often not a cure for these symptoms. If untreated, polycythemia can be fatal, and as it can cause blood clots, resulting in heart attack, stroke, pulmonary embolism. Labs that we would do is a complete blood cell count looking at the hemoglobin to be greater than 16.5 grams per deciliter, a hematocrit level of 49%, and a hematocrit level of 48%. Another diagnostic lab testing that we would do would be a bone marrow, take a bone marrow sample from the patient and look at it underneath the microscope. Now, we want to jump right into how we're going to treat and manage this problem. Let's go back to our case study of Jack as he presented with the fatigue, the itching, and the pain. We got his labs and we looked at them underneath the microscope and saw that he had an elevated hematocrit level of 67%. Treatment and management for him behind primary polycythemia is to reduce the number of blood cells in the body. In secondary polycythemia, the advanced practice provider should treat the underlying condition to reverse polycythemia. Bloodletting or therapeutic phlebotomy, no, I did not say lobotomy, is a treatment of choice to correct the number of blood cells in the body. In our case study, our gentleman did this for 3 months, 2 to 3 times a week to decrease the number of blood cells. He then developed more fatigue and bone pain, and he was also taking low-dose aspirin, which is a treatment of choice. According to Lynn, these are common symptoms of therapeutic phlebotomy. So now we are going to add a systematic anticoagulation drug called hydroxyurea. This is a myelosuppressive drug of choice due to the decreased incidence of leukemia and thrombosis. The newest development in 2022 reveals that roxolitinib also helps inhibit the pathway of the JAK2 gene and is showing positive results in multiple studies according to Rogers. So to wrap up this presentation, polycythemia is a rare disorder that happens when the body produces too many blood cells. I want you guys to always remember our little friend Jack, because with polycythemia vera, JAK2 gene mutation is involved, causing the disorder and correcting it, which involves a combination of therapeutic phlebotomy, low-dose aspirin, and potentially drugs that are systematic anticoagulation. I appreciate your time and taking the time to listen to my video, and thank you and have a great day.